Ladies and gentlemen, it's my pleasure to meet you to speak about intermittent versus continuous enteral feeding. My name is Jean-Charles Prézère. I'm working in the Erasmus University Hospital in Brussels. I have no conflicts of interest in relation with this presentation to declare. So continuous versus intermittent feeding of the critically ill is a debate, it's a current debate. We probably need to define what we are talking about. In this recent review just released by Zoe Plechet and myself, we drew this picture to show that continuous feeding, the upper line, is indeed continuous, while cyclic feeding is feeding provided to the patients during a continuous period of about 12 hours a day. Intermittent feeding mode is like this, so short periods of feeding, and bolus feeding is just push some food into the stomach. So with these definitions in mind, we can think about the rationale behind the switch from continuous, which is the most current mode, to intermittent enteral feeding. The simple answer is that intermittent feeding is probably more physiological, but physiological in terms of what? Of glycemic regulation, gastrointestinal motility, and potentially muscle mass and function. Let's start with the glycemic regulation. We know for long that hypoglycemia, and high glycemic variability are all associated with poor outcome in critically ill patients. In terms of glycemic regulation, the mode of feeding can modulate the release of insulin. So on the upper part of this graph, you can see that during continuous feeding, we can expect that the endogenous release of insulin will be continuous. While if we interrupt or if we give intermittent feeding or bolus feeding, the modes of release of insulin will be completely different with highs and lows according to the amount of calories given into the gastrointestinal tract. This is known as the incretin effect. The diabetologists know for long that when you give an oral load of glucose, the amount of insulin released following and triggered by the oral load will be much higher than if you give the same amount of glucose intravenously. This is the stimulation of the pancreas to release insulin and by some incretin hormones or some enteral hormones having incretin properties. We also know for long, at least in the field of diabetology, that this incretin effect is somewhat blunted in patients with type 2 diabetes as compared to control subjects. So in other words, the amount of insulin that the pancreas can release in response to a load of glucose or calories or a meal is lower in patients with type 2 diabetes. They have a smaller reserve of insulin into the islets of the pancreas. In the field of intensive care medicine, do we know whether intermittent versus continuous feeding change something in terms of glycemic regulation? We have this study on 50 patients having had gastrostomy, and they compared, the red line is intermittent and the blue line is continuous feeding. They looked at the glycemic variability and the mean caloric intake. In fact, to make a long story short, there is not any difference between the two groups in this particular setting. We can look at other data just released in CHEST last month by an English team in 8 ICUs in the UK. 121 patients were randomized to an intermittent versus continuous feed regimen. And they looked at different variables. We will have other variables later in this talk. But in terms of glycemic regulation and glucose metrics, they found that the intermittent mode of feeding was associated with a slightly, so these are the red dots. So the intermittent feeding mode is associated with slightly higher variability of blood glucose. The variability was calculated as the coefficient of variation. This is statistically significant. I'm not sure about the clinical relevance of this difference. In terms of glycemia, blood glucose, there was a delayed increase of blood glucose in the intermittent group, the red bars, as compared to the continuous group, with a lower need for insulin, maybe reflecting some incretin effect at the end of the ICU stay, or at least after 10 days of ICU stay. So the conclusion regarding the effect of intermittent versus continuous feeding in terms of glycemia is that the potential influence, which is really marginal. Second potential reason to choose intermittent rather than continuous is the gastrointestinal motility. We know for long that in healthy volunteers, Mother Nature designed us to have lunches and dinners and meals. So the contractions of the stomach are cyclic, not regular. And that this pattern is completely disturbed in critically ill patients. This is a slide from Alain Dive, published a long time ago in '94. You can see a disappearance of the gastric waves, just suggesting that the pattern of motility is disturbed in critically ill patients. There are a lot of reasons for that: the diagnosis, the comorbid conditions, the drugs, and the metabolic and electrolytic abnormalities. The consequence of this disturbed gastric motility is an intolerance, some level of intolerance to enteral feeding. Now, having said that, we probably need to agree on a better definition of gastrointestinal tolerance. As you can see on this table drawn by Annika Reintam, and this is a paper which has been submitted to Nutrition in Clinical Practice, different levels of gastric residual volume, regardless of the meaning of this number, different level of gastric residual volume has been chosen as cutoffs, or other symptoms with or without high gastric residual volumes has been chosen to define gastrointestinal tolerance. This heterogeneity is reflected by very wide variation in the prevalence of enteral feeding intolerance, which may range from 2 to 75%. Now, in terms of effects of intermittent feeding over continuous, we got a few studies. This is a study performed in 160 trauma patients, and you can see that the continuous line is intermittent route, while the interrupted line is the continuous route. And there is a small but significant advantage of intermittent feeding in terms of caloric intake. Now, when Lisa van Dijk and Michael Casar reviewed all the available studies on the effect of intermittent on or continuous feeding on the tolerance to enteral feeding, and this was published last year, there was not any significant or relevant difference. Now, in the guidelines published on behalf of the ISICEM last year in clinical nutrition, we recommended, according to the expert consensus, to use continuous, at least in the beginning of the ICU stay, rather than intermittent or bolus, because of the difference in the rate of diarrhea in 4 studies, about 240 patients in total. Now, the third reason why we could select intermittent is the issue of muscle mass and function. We know that critically ill patients lose muscle mass early during the stay, and that it takes much time to rebuild muscles. This picture shows a paper which was published in 2010 by the team of Rennie, showing that a bolus of amino acids is able to increase the fractional synthesis rate, so the buildup, the synthesis of muscular proteins very rapidly. And this is the reason why bolus feeding, like or intermittent nutrition, could be more effective in terms of muscle protein synthesis than continuous feeding. At least this was the support of the British study I showed you before, and I will show you again some data from this large study just released in Chest. They indeed saw that in patients receiving or randomized to intermittent feeding, there was a peak of leucine in the blood. So there was indeed an increase in the concentration of the amino acids, mainly leucine, but there was not any effect on muscle mass as measured with ultrasound. No difference between the two groups of 60 patients in each group. So to finish, ladies and gentlemen, I'd like to go back to some common sense. A patient who is getting better will recover his ability to eat. This is part of the nutritional rehabilitation in the ICU, but his food intake must be carefully monitored. We just released with some friends in Liège, Belgium, a paper in JPEN showing that the oral feeding in the critically ill patient was extremely low, well below. These are the darkest bars, so OF. Less than 50% of the requirements were provided orally. It may be because the patient is not hungry, but also that the nurses or the physicians did not pay enough attention to the amount of food provided and actually eaten by the patient. With that, I would like to thank you for your attention, and that's it.